Hello, everyone, and I warmly welcome all of you on behalf of IASNM MIBG webinar series. This session will have a 45-minute presentation, and this will be followed by a 15-minute Q&A session. You may submit your questions via the Q&A box throughout the session, or you can ask the questions at the end of this session, and we will address the questions in the orders that they are received. It is now my absolute pleasure to introduce Dr. Nadine Mallak, who is double-boarded Assistant Professor of Diagnostic Radiology at Oregon Health and Science University. Dr. Mallak is the Clinical Director of PET MRI Program and the Nuclear Medicine Program Director at Oregon's Health Sciences University. She is currently the President-elect of the Pacific Northwest Chapter of Society of Nuclear Medicine and Molecular Imaging. The scope of her clinical practice encompasses all aspects of molecular imaging and therapy, in addition to abdominal and pelvic imaging, with modalities including CT, ultrasound, and MRI. Her research interests focus primarily on molecular and hybrid imaging, particularly for prostate cancer, neuroendocrine tumors, and Pheochromocytoma and Paraganglioma. Dr. Mallak.
Good morning. Thank you very much for having me. It's a great honor. And I'm talking today about imaging of Pheochromocytoma and Paraganglioma, which has been kind of a hot topic in the last few years, with several agents that got FDA approved in the US since 2016 till now, with diagnostic imaging agents and also 2 radionuclide therapies, which are DOTATATE and Asst, which I'm going to touch base on a little bit today as well. So I have no disclosures related to this talk. This is the outline of my talk. So I'm gonna focus mainly on the agents that are clinically available for us, that we could use clinically in our everyday practice in the US. So as a quick introduction, Paragangliomas and Pheochromocytomas are neural crest-derived tumors. So they share the same histological findings under the microscope, with the main difference being that Pheo is a tumor of the adrenal gland coming from chromatin cells, and Paraganglioma is of the extra-adrenal in the sympathetic and parasympathetic ganglia. So typically the sympathetic paragangliomas, they can be present everywhere in the body, but mostly in the retroperitoneum. And one typical location is the organ of Zucker-Candle. Some of these can be present in the bladder as well. Now the parasympathetic paragangliomas, they're typically higher up in the upper mediastinum and the head and neck. In terms of diagnosis, these are rare tumors with an annual incidence about 1 to 8 per million. The biggest challenge is to suspect it at the first place. The diagnosis is made basically based on high catecholamine levels and anatomic documentation of the tumor. The classic clinical triad, which is very sensitive and specific, is diaphoresis, palpitation, and headache. And when you add the presence of hypertension to that, the sensitivity and specificity go up. Now, Pheo accounts for about 5% of incidentalomas of the adrenal gland, and we used to say that it's a 10% tumor, so 10% non-functioning, 10% in children, 10% outside the adrenal, and those are the paragangliomas, 10% bilateral, and 10 to 15%, we used to say malignant, but now the accurate word to describe it is metastatic, because all of these tumors carry a metastatic potential, so we just call it metastatic when it is, and although like only it's about 10 to 15% of Pheo that get metastatic, this the occurrence of metastatic paragangliomas is higher. It's in the order of 35 to 40%. Now, a very interesting feature of these tumors is the genetic heterogeneity, that they're very often associated with germline mutations and susceptibility genes. So it's about 30 to 35%. And we add to that 35 to 40% that show somatic driver mutation. Although this genetic heterogeneity is present only about 5% of solitary Pheo, it goes up to 70% in patients with multiple Pheos or in Pheo plus paraganglioma. So ideally, all patients presenting with Pheo or para should undergo genetic counseling. Now, some major predictors for hereditary Pheos and paras are family history of these tumors, previous personal history, multifocality, early age at onset, and if they have characteristic syndromic presentations. I'm going to talk a little bit about these presentations. So the genetic mutation is often unknown at presentation, but the metastatic potential, it has a multifactorial risk assessment. So if the tumor is large, more than 5 centimeters, if it's extra-adrenal location, presence of certain mutations, typically the SDHB mutation, dopaminergic phenotype, and high Ki67 or proliferation index. So we have 3 clusters of mutations that are identified, and the genotype affects the biology and the pathogenesis of the tumor. So it should be considered in guiding personalized care. So I like very much this image that I adapted from this paper right here. So this goes over the 3 clusters. So cluster 1 is the pseudohypoxia, cluster 2, the kinase signaling, and cluster 3, which is the most poorly understood, is the WNT signaling. So we know much more about the pseudohypoxia and the kinase signaling. So the pseudohypoxia cluster, luckily, it represents a smaller percentage of Pheos and Paras. The majority are actually kinase signaling. So the kinase signaling are the ones that typically occur in the adrenal gland and in the retroperitoneum. They're well differentiated. They carry a lower risk of metastatic disease. So it's about 4%. On the other hand, on the pseudohypoxia cluster, especially cluster 1A, which is associated with the SDH mutations, although it represents a fewer percentage of Pheos and Paras, it is the least differentiated, and it carries a higher risk of metastatic disease. So the risk of metastatic disease for cluster 1 is about 24%, but in cluster 1A, it's higher, and especially higher with SDHB mutation. So those are the mutations that we encounter more often. So the NF1 and the RET, or this is what's associated with the MEN syndrome. So these, although we have, like, we can have, these patients can have recurrent Pheos or Pheos of both adrenal glands. Typically, they're on the well-differentiated side and they don't metastasize as much. On the other hand, patients with the SDH mutations, they too metastasize quite a bit. So the most relevant genetic syndromes that are associated with Pheos and Paras that are important for us as radiologists and nuclear medicine physicians to recognize, because they can have multiple tumors that we can see on our scan. Von Hippel-Lindau, so they have Pheos. They could have also renal cell carcinoma, cerebellar and spinal hemangioblastomas, and retinal angiomas. The MEN2 syndrome associated with a RET mutation, so they can have medullary thyroid cancer, uni or bilateral Pheo. And if it's a MEN2A, they can have also parathyroid hyperplasia. MEN2B, they could be associated with just mucocutaneous neuromas. The NF1 tumors, they can be associated with the typical neurofibromas and plexiform neurofibromas and malignant nerve sheath tumors. And the paraganglioma syndromes 1 to 5, so those are the ones associated with the SDH mutations. They present predominantly with multiple paragangliomas. So to start quickly with anatomic imaging. So it is a very difficult diagnosis to make prospectively when we have a pheochromocytoma of the adrenal gland. Sometimes the findings are just not specific, but there are some features that can help us suspect it. So the first teaching point is that the non-contrast density of all of these is almost always more than 10 Hounsfield units. So basically, if we have a nodule, an adrenal nodule on a non-contrast CT with the density less than 10 Hounsfield units, we can almost be certain that this is an adenoma. So this is a helpful feature. And then the findings can vary by lesion size. So if they're larger, then they can be cystic or hemorrhagic as well. So the most helpful feature, though, on CT is the avid enhancement. So we could think of it as a type of neuroendocrine tumors, which enhance quite a bit. So if we have a portal venous density of more 110 to 120 Hounsfield units, then we should include pheochromocytoma in our differential for these. And an important teaching point is that about 30% of these can have washout in the adenoma range. So basically, if we do an adrenal protocol CT and we have an absolute washout of more than 60% or relative washout more than 40%, which usually we use to say that this is an adenoma, if we do have a high enhancement, then we should include Pheo in the differential. So this is an example of a pheochromocytoma of the right adrenal that's presenting enhancement with, here the density is 120 Hounsfield units, and it does have a cystic component. Now on MR, the most helpful feature is the presence of this T2 brightness, which we call light bulb bright signal on T2. So this is a finding that's suggestive of Pheo. And also similar to CT, some of them can have cystic or hemorrhagic components. And also the presence of intracellular lipid is basically diagnostic of adenoma. So if we have a lesion that presents a drop of signal between the in-phase and out-of-phase imaging, then we can be sure that this is an adenoma. And if we see this T2 brightness and the avid enhancement, then we should suspect a Pheo. This is another example here, a Pheochromocytoma with T2 brightness of the solid enhancing component and a cystic component in the middle. Now for paragangliomas, the majority of the sympathetic ones are in the retroperitoneum, and the imaging features are similar to Pheo. Now the differential here is metastasis and lymphoma. And so for these, we often need a biopsy. And an important thing to remember is before we stick a needle in a lesion that might be a Pheo or a para, we need to appropriately prepare the patient with alpha blockade. Otherwise, they might go into catecholamine crisis. So if we see a lesion that might end up being a para, we do biochemical testing beforehand. Now for parasympathetic paragangliomas, those are higher up, upper mediastinum and head and neck. And so they're painless, they're slow growing. Mostly they're non-secreting, but when they do, instead of norepinephrine and epinephrine, they do secrete dopamine. And they're most often hereditary than the sympathetic paragangliomas. The locations are carotid body, glomus jugulare, glomus vagale, and glomus tympanicum. So this is an example of a left carotid body tumor with T2 brightness and avid enhancement. And then on the MRI features, a classic appearance is the salt and pepper. And the salt and pepper is typically because of the high vascularity. So we have flow void in the vessels. And also because we can have a little bit of blood products that can give the salt and pepper appearance on T1 weighted images. This is an example here of right glomus jugulare on MRI, and we see the salt and pepper appearance on both T1 and T2. Now, if we see multiple lesions, then we should raise concern for a genetic syndrome. So this is an example of a patient with von Hippel-Lindau. And all the lesions I'm showing here were pathology proven. So this patient presents an avidly enhancing nodule of the right adrenal gland. So here the density is 187 on the arterial phase, and it's 123 on the portal venous phase. So it's avidly enhancing. This was a Pheo, and we have a smaller Pheo of the left adrenal. We have a paraganglioma in the retroperitoneum and the neuroendocrine tumor of the pancreas. So in terms of screening for carriers of genetic mutations, particularly the SDH, so based on which mutation it is, the metastatic risk is a little different, and the location of the tumors are a little different as well. So the mutation that carries the higher risk for metastatic disease is the SDHB mutation. But despite the risk of metastatic disease, these patients still have a favorable prognosis. So this is a study that included children and adolescents carriers of SDHB mutation that shows overall survival estimated at 5, 10, and 20 years of 100%, 97%, and 78% respectively. So, and the younger the patient is and the smaller the tumor at first diagnosis, the better the prognosis is. So despite the fact that they could be metastatic, they do have a favorable prognosis, and we're going to have to image these patients for a long period of time. So this is like, although we said that the mutation status is often unknown at presentation, there is one helpful feature when we biopsy the tumor, is we can have immunohistochemical staining for the SDHB mutation, which is quick, and it identifies patients likely to have this mutation on pathology. So while we're waiting for the genetic testing, after we do the biopsy, we could ask our pathologist if they actually can stain for this. And it has a reasonably high sensitivity and specificity for this. So here I'm showing you a case of a lesion in the right hepatic lobe. So here we did not suspect paraganglioma, so we didn't prep this patient prior to biopsy. We just biopsied. Luckily, they didn't go into catecholamine crisis. And this turned out to be a paraganglioma. And here, like I just copied and pasted the path report, which says liver involved by SDH deficient paraganglioma. So just because of the staining. So they say the tumor cells show loss of SDHB, with appropriate internal positive internal control. So the loss of SDHB protein expression is closely associated with a mutation in the SDH complex and often correlates with the germline SDH mutation. And so this is helpful just to know that this patient basically has an SDH mutation, and now while waiting for the genetic testing, we just have an idea of what we're probably dealing with. And so this is very helpful. And so in terms of screening for these patients, so as we said, they have a favorable diagnosis, and we're going to be following them up for a long period of time. So if you have a younger individual with an SDH mutation, we're going to be following and screening them all the time. And so radiation exposure is a concern for these patients. So that's why we screen them with a whole body MRI rather than CTs and PET CTs. And then, and the frequency of these scans depends on the mutation. So if it's a patient with a cluster 2 mutation, the kinase signaling with lower risk of metastatic disease, then we screen every 5 years. If it's an SDHB mutation, every 1 to 2 years. And if we see a suspicious lesion, then we have to investigate this further. So the functional imaging is recommended at initial screening for adults, but not for pediatric population so far. So this is just an example of our protocol for whole body MRI, where we get T1 images, T2 FAT-SAT, DWI, and T1 post-contrast. So now let's get to the functional imaging. So clinically available agents that I'm going to be focusing on today are iodine-123 MIBG, gallium and copper DOTATATE, and FDG. So there are other very helpful agents, particularly the F-DOPA, but it's not commercially available for us to use in the US. So I'm going to be mentioning that briefly in the talk, but I'm not going to be focusing the discussion on them. So the key indications to get functional imaging is diagnosis and localization in patients with elevated catecholamines, staging prior to surgical resection, and this is particularly for large tumors and for tumors that have aggressive features on biopsy or non-germline mutation, staging of multifocal or metastatic disease, screening or surveillance of patients with genetic mutation, and this particularly if they're adults initially, and selection for radionuclide therapy in non-resectable or metastatic disease. So to start with MIBG, which is our oldest and most classic agent that used to be used for these tumors. So it's a norepinephrine analog. So the uptake mechanism is energy-dependent active transport. So Pheos and Paras, they do express norepinephrine transporter on the cell membrane, through which catecholamines can enter the cell and be deposited into neurosecretory granules via the vesicular monoamine transporter system. So these VMATs are very important because if the tumor expresses them, then we're gonna see uptake on MIBG most likely, especially VMAT1. But if the tumor does not express VMAT1, then we're not gonna be able to see it with MIBG. So the patient's preparation is with thyroid blockade and discontinuing interfering medications, and there's a long list of these medications that we need to check prior to the scan. So if we want to characterize a lesion suggestive of Pheo or Para, and classically if it's in the adrenal gland where MIBG works best, so we're going to see a nodule on CT in the adrenal or in the retroperitoneum if it's a paraganglioma. So for Pheo, the sensitivity and specificity is quite high for MIBG, but it's lower for paraganglioma. So this is an example, a patient with a nodule of the right adrenal gland is relatively large, and this patient got a MIBG scan, and this confirms the uptake in the tumor, and that this is a Pheochromocytoma. Now, to evaluate patients with genetic syndromes, so this is an example of a patient with a MAN2B and history of medullary thyroid cancer. So they presented with mildly elevated urine catecholamines and bilateral adrenal nodules on CT. So we got the scan, and the scan confirms uptake in bilateral adrenal nodules, and we see this uptake on SPECT CT. So this is basically, this patient has bilateral Pheo. So this is just a reminder that although we have bilateral adrenal Pheochromocytoma in this patient with MAN2B, these Pheos tend to be on the more differentiated side and they metastasize less. And for MAN2B, for the cluster 2, MIBG works well. So for the tumors in the adrenal gland, it works really well. So this is a patient, it's an 8-year-old male presenting with abdominal pain and vomiting, and they got a scan of their abdomen and pelvis, and we see the centrally necrotic tumor in the retroperitoneum, suspicious for paraganglioma. So here we got an MIBG scan, and there is uptake in this nodule here, and we see it quite well on SPECT CT. So this tumor was taken out, and the patient has been followed since then with MRI because they're young. And so after a long period of time, after 9 years, so as we mentioned, these are like really slow growing and they can recur really later on during life. So 9 years later, the MRI shows 3 enhancing nodules in the retroperitoneum. So at this point, an MIBG scan was done again, and this was a few years ago before the DOTATATE was clinically available in the US. And we see uptake in both of these retroperitoneal nodules. The third, though, the highest one, is not showing uptake with MIBG. So here already we have heterogeneous disease, which we can see occasionally. So we can see tumors where certain lesions show uptake with a certain agent, others, though, don't show uptake with this agent, show uptake with another one. And so this can happen occasionally. So for definition here, before we start talking about metastatic disease, that multifocal disease is different than metastatic spread. So multifocal disease is when we have more than one pheo or para, but the disease is confined to the adrenal glands or to the sympathetic and parasympathetic ganglia. So metastatic spread, if we have disease outside the adrenals and ganglia. So if the disease is in lymph nodes, lung, liver, and bones, it's typically metastatic. Although we can have primary paraganglioma in the lung or liver, but it's really rare. So to say that there is metastatic disease, the disease has to be outside of the ganglia and adrenals. So most of these are sporadic, but when hereditary, the SDHB mutation is the most common culprit. So although we said that MIBG is highly sensitive for pheos, and for sympathetic para, the sensitivity drops for metastatic and familial pheo and para significantly to about 53 to 60%, and it's less than 50% with SDH mutations. So in these scenarios, PET agents are preferred, gallium and copper dotatate and FDG PET. Now here, before I start talking about dotatate and FDG, I just want to mention briefly that FDOPA is a very helpful agent for to image the catecholamine pathway. And it has a much higher sensitivity than MIBG. So with MIBG, you need the tumor to express VMAT1, but FDOPA shows uptake in tumors that are MIBG negative. And the theory behind that is this could be because the FDOPA can also show tumors that show VMAT2 expression, not just a VMAT1 expression. So for the catecholamine pathway, FDOPA is a better agent than MIBG. Unfortunately, it's not available for us clinically to use in the US. So the two agents that we refer to are dotatate and FDG. So somatostatin receptor PET is very helpful because pheos and paras are a type of neuroendocrine tumor, basically, and they do express very commonly somatostatin receptors. And so our PET agents replaced octreoscan. They have much higher sensitivity, much higher specificity, much lower radiation dose to the patient. So the first agent was gallium dotatate that was FDA approved in 2016. And then in 2020, we got copper dotatate. And so now we have these two agents that are considered clinically to be equivalent. FDG PET images metabolism in the tumor, so it accumulates in the tumor proportionate to the glucose metabolism. So which one to use and in which scenario? So if you have a lesion of the adrenal gland, so as we said before, MIBG works very well. Dotatate PET works very well also in these lesions. And some papers show it to be a little bit superior to MIBG, actually, even for primary, sporadic, and non-metastatic sympathetic pheo and para. And this is most probably because of the better resolution of PET compared to SPECT technology. And this is an example of a right adrenal pheo here showing increased uptake. Now, in this scenario, of course, we have like first the physiologic adrenal uptake. And second, that occasionally benign tumors of the adrenal can show uptake, like an adenoma, for example, with dotatate. And so it's not, it sometimes can be difficult, I should say, that to say for sure that it's actually pathologic, that uptake is pathologic, especially if the nodule is small. on anatomic imaging. So now let's look at how these different functional agents compare for metastatic disease. So to start off with MIBG versus FDG. So this is a prospective study that was done on 216 patients evaluated for suspected Pheo and Para. So for non-metastatic disease, the sensitivity of FDG is somewhat similar to MIBG. However, we see that based on the mutation, one agent might be better than the other. So if we're dealing with an SDH mutation and VHL, FDG had a sensitivity of 100% versus 80% for MIBG. But if it's a MAN2 mutation, FDG sensitivity dropped to 40%, but MIBG was very sensitive. So based on the genetic mutation and the signature of the tumor, one agent might be better than the other. For metastatic disease, FDG performed much better than MIBG. And this is one of the examples they show in this paper, a patient with SDHB mutation. So we see this lesion quite well on FDG PET, while it's MIBG negative. Now, how about DOTATATE versus FDG? So DOTATATE has been shown to perform in multiple papers, has been shown to perform better than FDG. So this is one of the papers with 34 patients. So the per lesion sensitivity for DOTATATE was 96% versus 91% for FDG. Now, one caveat here that 2 liver lesions were seen only on FDG, and the idea that the uptake might have been masked by the high background uptake on DOTATATE in the liver. So this might be the reason why these two liver lesions were not seen quite well. So the DOTATATE showed higher lesion to background contrast, and more lesions were seen per patient, but did not alter the stage or the management of the patient. And this is one of the examples where we have metastatic paraganglioma, and the tumor was metastatic. We see the metastatic disease on both, with more intense uptake on DOTATATE. And this is a patient with an SDHD mutation. So this is a paper that looked particularly at patients carriers of SDHB mutations with metastatic Pheo and Para, and DOTATATE performed better than all other agents, better than CT-MR and better than FDG, and better than FDOPA here as well. So FDOPA, as we mentioned initially, is a good catecholamine imaging agent, but it doesn't perform as well for SDH mutations. So for SDH mutations and locations in the head and neck, DOTATATE across the board is the best agent to use here. So the lesion-based detection was 98.6% for DOTATATE, and it was lower for FDG. And this is the last study I'm going to go over, and this is a meta-analysis of 13 studies that basically excluded those with exclusive subtypes. And here they were trying to mimic basically the population that comes to us in clinic. So if I open a scan and I want to read a scan for a patient and I have no idea what the genetic mutation is, so basically this is somewhat representative of this population. And so the DOTATATE here showed a much higher performance compared to the other agents. Now there is one paper here that showed a higher performance for FDOPA, but this was done for an exclusive subtypes actually, which was polycythemia paraganglioma syndrome. So and it's a relatively rare mutation, so it's not representative of a general population. So the studies that have been done so far show that gallium DOTATATE can actually serve as a first-line imaging for these tumors. So I'm going to show a few cases from our practice. So as we mentioned, DOTATATE is emerging as the first-line imaging for all Pheos and Paras combined across different mutations. And so the detection rate is reported as high as 98% with this agent. So this is particularly useful for SDH mutations, head and neck, and metastatic disease. So this is an example of a patient with SDHD mutation, bilateral cervical paragangliomas. So this is just multifocal disease. However, recently the patient presented with worsening headache, hypertension, and tachycardia. And on CT, we saw liver lesions. Biopsy confirms paraganglioma. So now we have metastatic disease, not just multifocal disease, and it's in the liver and also in the bones. So we have 2 small metastatic lesions in the bones. And see on MIBG, the study is completely negative. Now, this is an example that compares metastatic to multifocal disease. So here we have a patient with metastatic disease. The patient is carrier of SDHB mutation, and the disease is metastatic to lymph nodes in the right axilla and to the bones. And we see how a lot of these bone metastases were completely occult on CT. So we see them mainly on our PET scan, on our DOTATATE PET scan, and it's a very strongly positive scan. Now, on the other hand, the patient to the right of the screen has multifocal disease, and this is a patient also carrier of SDHB mutation. Now here, this patient had a strong family history. So the mother has metastatic functional para and SDHB gene mutation, two uncles with Pheo, and this patient presented with a mesenteric mass. So this was resected, and this was found to be a paraganglioma. And they had a Radionuclide paraganglioma as well. So this was multifocal disease and not metastatic at this point. So FDG PET has been shown to be superior to MIBG, especially for metastatic Pheo and para, and with those with SDH and VHL mutations. But DOTATATE, since it has been approved, it has been shown to be consistently better than FDG for the various mutations. So this is an example of a patient with carotid body tumor that was resected 27 years ago, presenting with metastatic disease to the lumbar spine. And so we don't have genetic testing here. We don't know what mutation is present. We see the FDG uptake in the lumbar tumor, and we see some metastatic bone lesions, but on the DOTATATE scan, we see higher uptake in this lumbar lesion. And also we see higher uptake in many of the osseous lesions as well. The head and neck paragangliomas, they do deserve like a little separate discussion because a little bit different. So they're tumors of the parasympathetic chain. They have higher association with the SDH mutation, and they do show increased expression of somatostatin receptor. And so DOTATATE PET is consistently shows the highest detection rate for these tumors. FDG PET works well, but less than DOTATATE. So this is an example of a patient with hereditary Pheochromocytoma with SDHD mutation. So the DOTATATE PET shows multifocal paragangliomas in the head and neck. So patients with SDH mutation to wrap up are at higher risk for multifocal and metastatic disease. Patients with SDHB mutation particularly have the highest risk of metastatic disease, at least 30%, and a shorter survival compared to the other mutations. So a 5-year survival rate after diagnosis of first metastasis for patients carriers of SDHB mutation is in the order of 36% versus 67% in patients with metastatic disease but no SDHB mutation. So this is basically has the highest, is the most common culprit for more aggressive disease and poorer prognosis. Now, this is another patient with SDHD mutation and multiple head and neck paragangliomas. They've had multiple resections previously and followed by tumor recurrence. So we see the DOTATATE PET and in comparison to the MIBG scan. So I like this case because also there's a pitfall here on the MIBG. So symmetry is our friend in nuclear medicine. So if you look here and there is uptake on the right, so it might be confusing at first. But this is just physiologic uptake in the parotid and submandibular gland on the right, while on the left side, the patient had prior surgeries and prior radiation to the left neck. And so the parotid and submandibular gland are atrophic. So this is just physiologic uptake, and the tumors are completely MIBG negative. So this is it here on SPECT. The paraganglioma is negative, while it is strongly positive on DOTATATE. So we see multifocal paragangliomas in the neck here, and we also see a paraganglioma in the mesentery of this patient. Now let's get to patient selection for therapy. So it has been very exciting in the last few years that we had 2 therapies that work quite well for these tumors. So, and they were both approved in 2018. Lutetium DOTATATE or Lutathera was approved for gastroenteropancreatic mets, not for Pheo and para, but we use it off-label for Pheo and para. And we have the iodine 131 or high specific activity MIBG or Asst. So this was approved as a first-line therapy for Pheos and paras. So although like both of these tumors, both of these agents can be used for therapy, and although Asst is the first line, the choice ultimately should be based on the degree of uptake on pre-therapy imaging. So one important question for these tumors is when to treat. So because as we mentioned before, these patients do live for a very long time. And despite the presence of metastatic disease, the prognosis can be favorable if the progression is slow. So here is basically, we have this agent that we could use, but when is the best time to use this tool on this tool that we have? So typically, we reserve the treatment for patients with disease progression, and the progression could be clinical or on imaging. So if patient is having worsening symptoms, then it's definitely the worsening symptoms are don't just impact the quality of life, but they also impact survival because they're bad for the cardiovascular system. So we do treat these patients if clinically they're doing worse or if they're progressing on imaging. Now, an important thing to consider is that these patients can potentially go into hormonal crisis when we treat them. So it's not common, and it's more common in functional tumor than non-functional tumor. So it can cause hypertension, myocardial ischemia, pulmonary edema, and shock. So we may need a combination of alpha and beta adrenergic and calcium channel blockade. So the way we deal with this is if the patient has functional disease and they have symptoms from their disease, we prep them. If not, if it's a non-functioning tumor, we don't prep them ahead of time, but we're always aware, and our endocrinologists, we make them aware that basically we're treating these patients, and if a hormonal crisis occurs, so they're on standby. So the trial evaluating AZEDRA for patients with advanced Pheo and Para, which was a phase 2 multicenter open label trial to evaluate efficacy and safety. The primary endpoint here was dropping by 50% the antihypertensive medications used for at least 6 months. So that was the primary endpoint. It wasn't the survival, and it wasn't tumor shrinkage. It was reducing antihypertensive medication. And 25% of patients achieved this endpoint. Secondary endpoints were objective tumor response and biochemical tumor marker response, overall survival and safety, and 92% of patients had partial response or stable disease with this agent. And this is the chart that basically shows the tumors who had who shrunk over time. So just to show a few examples from our practice for patient selection for therapy. So this is a patient with a right adrenal Pheo resected 1 year ago, continued rise in metanephrine with severe symptoms. So the patient was having worsening headaches and tachycardia that would wake him up at night. And so this patient was referred to us, and the FDG PET was done already. We don't do FDG PETs for these tumors. We do MIBG and DOTATATE all the time before treating them, but we don't do FDG typically. This patient just came to us with this scan, so that's why I'm showing it. And so we see the tumor showing increased MIBG uptake. It shows uptake as well on FDG and DOTATATE. And you can see that like some of the small lesions, we see them actually a little better on MIBG. So this patient, because of the uptake, like there were no lesions that were DOTATATE positive, MIBG negative, so all disease was MIBG positive, we went ahead and treated this patient with AZEDRA. Now when we want to treat with AZEDRA, we have to do dosimetry ahead of time. So the dosimetry is required here to calculate the maximum allowable activity for each patient. So the way we do that, we inject the patient with 5 millicuries of iodine-131 MIBG, and then we do whole body imaging at 1 hour, 24 hours, and 72 hours. So here, just to note that with time, we see decreased uptake in physiologic organs. So here, for example, the liver shows decreased uptake. The agent washes out from the blood pool and physiologic organs. And we see accumulation in the metastatic lesions. And when we image, we have a standard here. So this is a standard dose that we use to actually calculate the uptake in the lesions and in physiologic organs. So using our Olinda software, based on these 3 time points, we contour the organs of interest and we calculate the dose that each organ would get for each millicuries. And that's how we get to the maximum allowable activity. So this patient for 2 cycles is allowed to get up to 1,000 millicuries. So we went ahead and treated with the full dose. First dose 500 millicuries, the second 500 millicuries. And so this because iodine-131 allows us to get imaging with its longer half-life and the gamma emission, we do image patients before they leave the hospital. So we, because of the high activity we're giving here, 500 millicuries, all these patients are treated as inpatients. And they get quite sick with this therapy. So they're really tired, they have nausea and vomiting. It's really, it takes a toll on patients like for the first few days. So we do discharge them when they meet criteria for discharge from the hospital, typically around the 4th day. So we image them before they leave. So this is, the image here is after the first cycle from anterior projection. And I'm comparing it side by side with the images after the second cycle. So after the second cycle of therapy, also images from anterior and posterior projection, we see how the tumor is responding. So we see the decreased uptake in the lesions. So some of the lesions disappeared on the subsequent cycle. And also, we don't see the star artifact anymore that we saw in some of the lesions, and we have higher uptake in background. So, and the patient symptomatically was doing way better. So this was a really good outcome that we were very happy with. Now, case 2, some tumors present with heterogeneous uptake with the multiple agents that we have. So this is a patient with a history of multiple head and neck and abdominal paras in the setting of SDHB germline mutation. They've been treated with surgical resection multiple times, and now they're presenting with progressing metastatic disease and increasing catecholamine levels. So here the patient is presenting with iodine 123 MIBG scan, but before every therapy, we image with both agents. So we image with DOTATATE as well. So you can tell here that there are more lesions that we see with DOTATATE, but we have to pay attention to the fact that we don't want to be fooled by the higher sensitivity of the PET technology. So we want to look at the actual uptake, like is the tumor taking up MIBG or not, and not just the intensity, which could be secondary to just the PET technology being better than SPECT. But here, when we look at the cross-sectional imaging, fused images, so there are, the MIBG shows the osseous lesions quite well, but there are also metastatic lymph nodes in the mediastinum and in the supraclavicular area, and those are MIBG negative, but they're DOTATATE positive. So based on this, the tumor is heterogeneous, but there are more lesions showing uptake with DOTATATE than MIBG. So here we went ahead and we treated this patient with Lutathera. So this is pre-PRRT and post-PRRT. So here we have like the isotope is a little different between the two, but we still, like, despite that, we could see that there is some partial response here. So there are some of the small lesions have disappeared on the subsequent scan, and patients also had response on labs and improvement in their clinical symptoms. And sometimes, like, this is the third scenario where we could have this like more straightforward with like clearly one agent should be used here. So this is a right carotid body tumor resected 11 years ago, presenting with pathologic fracture of the right acetabulum. So the patient, the biopsy here showed that it's a metastatic paraganglioma. Genetic testing reveals SDHA mutation. So here on DOTATATE, we have intense uptake in these lung and osseous metastases, MIBG negative typically, and so which is not uncommon with these SDH mutations. And so based on this, we treated with Lutathera. So in terms of for treating with Lutathera, so we have several cohort studies published between 2008 and 2021, and they involve about between 5 to 30 patients. So they're like really small series that looked at Lutathera for inoperable or metastatic Pheo and Para. They show promising results. Now there's an ongoing NCI-sponsored clinical trial to evaluate PRRT Lutathera in therapy of inoperable Pheo and Paraganglioma. So we're looking forward to seeing the results of this study for these tumors. So summary of which tracer to use and in which scenario. So prior to radionuclide therapy, we always use both systematically. We image with DOTATATE, we image with MIBG, and we look at the degree of uptake on each scan. And we treat with the agent that we think is going to target more lesions. So for imaging only purposes, so for example, if you want to characterize a lesion, or if you want to stage prior to surgery, or to follow up patients who are known to have metastatic disease, overall, DOTATATE has been shown to be the best first-line imaging for all Pheos and Paras. Now, if F-DOPA is available, then we might want to consider F-DOPA for tumors that are in the adrenal and retroperitoneum, basically, and for tumors who are in the kinase signaling cluster. But if F-DOPA is not available, which is the case here, we do image with DOTATATE as first line. Now, if you want to go to the nitty-gritty of how the scheme is, so basically, we don't know the mutation status most of the time. We can sometimes guess that, as I said, on immunohistochemical staining from the biopsy site. If you have cluster 1 tumor, then DOTATATE definitely. If the mutation is still unknown, then we go by location, outside abdomen and pelvis, DOTATATE definitely. If it's in the abdomen and pelvis, or if you have a cluster 2, then DOTATATE is still superior to MIBG, but some people who have worked a lot with these tumors, they say that occasionally, rarely, but you can see some tumors that show more MIBG uptake. So this is something to keep in mind, that we might need both agents for this specific subtype of tumors. So the take-home messages: most Pheos and Paras are associated with germline or somatic mutations. The genotype should be considered to guide imaging and therapy. Common scenarios for negative MIBG scan: extra-adrenal, particularly head and neck, metastatic disease, hereditary germline mutations. DOTATATE PET is the first-line imaging agent. And this is particularly for SDH mutations, extra-abdominal and metastatic disease, and it outperforms FDG. So MIBG and DOTATATE both have theranostic properties, and the choice of therapy should be based mainly on tumor uptake with both agents. And thank you very much, and I'm looking forward to hearing the questions.
Thank you very much, Nadine. Excellent talk and very comprehensive overview of Pheo and paragangliomas. So there are a few questions in the chat box. So I'll read out the first question, which is by Dr. Achit. So he asked, in the evaluation of adrenal incidentallomas, a population of tumors are lipid depleted, which conspicuously show tumor attenuation of less than 10 Hounsfield units. What additional imaging helps to rule out Pheo or paragangliomas and will clinch the diagnosis?
Yeah, so for adrenal incidentallomas, it's Pheo has been shown to be in about 5% of incidentallomas, and it is an autopsy series, which is also higher than what we see in clinical everyday practice, because those patients who go to autopsy or to go to surgery basically have some suspicious features. So basically, like the typical adenomas don't go to surgery. So our pathology series tend to have a higher proportion of Pheos and also of malignancy. So basically, in real life, adenoma is the most common, statistically speaking, most commonly, even if it's an incidentalloma that we don't know what it is, and patient presenting without any abnormality, labs are okay, then it is an adenoma. 80%, more than 80% of the cases that have been proven, and in real life, even more than that. So going from the statistically, it's most commonly an adenoma. If labs are negative and there are no features concerning for Pheo or para, then we could basically leave the patient alone. And there have been studies that show if we're going to go further on the route on following up these patients and doing more testing, basically we're gonna increase the cost and radiation to patients with no additional value. So that's just from a clinical practice. As a body imager like myself, so endocrinologists like to see patients with these incidentallomas and rule out that they have there's no biochemical, that the biochemical testing is negative. And if that's the case, then that's it. We don't pursue functional imaging for adrenal incidentallomas unless there's a reason for that.
Thank you. You very well explained. And next question I jotted down, but I got the answer in your discussion. What has been your experience in treating metastatic paragangliomas with PRRT versus MIBG? And you very well explained it, it's personalized medicine based on what you see on imaging, what the patient has, looking at the comorbidities and all that. One of the things which is not a question, but just a discussion point, when we think of MIBG therapy versus PRRT, personally, I think PRRT is a more neat and easy to administer therapy compared to MIBG with your too much restrictions and all that. And of course, dosimetry is something which is supreme. And I think that's a great thing that you guys are doing at your institution. That always gives you an informed decision-making of what is the safe highest dose.
Yes, exactly. At the series, like we really have no comparison. We have no data to say, like, does PRRT work better than MIBG? Like if a tumor is expressing both, of course, like if it's expressing one and not the other, then basically the choice of therapy is clear. It should be like what the tumor is going to be treated with. But like, let's say the uptake is similar on both. There's really no data to say that one agent is going to be better than the other. So at our institution, because we have both available, we go with Azedra because it's the first line FDA-approved therapy for these agents. But like some places, because the therapy is not widely available, as you mentioned, it is a very involved therapy, and so some places don't have the capacity of doing that. So some places just do Lutathera because it's available. And it can be done for these patients, while it's very, it's going to be like, they're gonna have to send patients to another institution and travel and get, so it's not practical to get the etc. But yeah, looking forward like for more data on that. And the fact that it is a very rare tumor, it doesn't help because you have like these small series, and the prospective trials take a very long time to get done and to have actual results, clear data. So
yeah, thank you. And the next question is from Dr. Amal Takalkar. And he asked, how are you doing I-131 MIBG therapies in adults? And if yes, how are you getting reimbursed for those? And what kind of funding mechanisms one can pursue for things like this in US?
Yeah, so for MIBG therapy, it is an FDA-approved therapy for Pheos and Paras. So we just get reimbursed by the regular means, like insurance companies pay for it, and Medicare pays for it. So we haven't found any problem getting the MIBG therapy reimbursed, and we didn't have problem getting PRRT reimbursed for these patients either. But those patients that we treated with PRRT, there was like clearly an indication for doing so. So the tumor was not showing up MIBG uptake as it should. So it was higher uptake on DOTATATE. So we ended up treating with PRRT, but we have no issues with reimbursement. Yeah, as long as like the imaging or the therapy that we're doing is FDA approved for the indication.
That's very good. That's very good to know, Nadine, because it's an expensive treatment, and sometimes, insurance companies give a pushback. But if your experience has been great, so it's good to know that.
So Nadine, I just want to add on that. These are inpatient therapies, so they get bundled and they're very expensive. So do you have any details, or can I reach you offline to see if you're not really losing money on this? Because that has been our experience, that since these are inpatient therapies, whereas Lutathera is outpatient therapy, so you can directly bill and you don't lose your shirt over it. Whereas with AdReview, it's just not possible. Even the copay for coinsurance for most patients is unaffordable. So I'm just curious how you're getting all that reimbursement. So if you can shed some light, or I can reach you offline.
Yes, I mean, what I know is like it hasn't been like we haven't been losing money on these. But if you want to email me, I can put you in contact with our clinic manager and with people who actually deal with reimbursement, so they could answer like really, they could answer this much better than me. And my email is just my last name, mallak@ohsu.com, and I could put you in contact with the clinic manager who deals with this.
That would
Perfect.
be great.
Thank you.
And I'll also share the email with Dr. Takalkar. I have your email. And Dr. Takalkar also and I work in the same institution. So it would be great. The next question is from Parveen. And the question is, what's the percentage of non-secretors pheochromocytoma in clinical practice?
Yeah, so in clinical practice, if the patient, if it's just a pheochromocytoma, non-metastatic, just a sporadic, a lot of these are secretors, and they're mostly in the adrenal glands. And even if it's a sympathetic paraganglioma, they're mostly like 60% of them are on the well-differentiated side, and mostly they're secretors. Now, the patients that come to us, to nuclear medicine, and they have metastatic or multifocal disease, I would say probably the majority of them are non-secretors, just because the cluster 1 tumors, the non-secretors, have a much higher propensity for this, for multifocal and metastatic disease. So in our practice, more than half have been non-secretors. And basically, we treated about half and half with MIBG and with Lutathera for these patients.
Great, thank you.
Yeah, hi ma'am, good evening. This is Parveen. I'm joining from India. And this specific question is, first of all, ma'am, I really congratulate you for this talk. This was really good. It cleared lots of our doubts. But this question is specifically because I have been facing this problem. I'm in tier 3 city, and we have started this comprehensive nuclear medicine center here in, like it's near to the Delhi, but it's tier 3 city. So recently I got 2 patients. They were suspected Pheo, and this is like research crunch setting. So we cannot ask them to get like this genetic mutation is totally out of question. And on the basis of clinical symptoms, they were like suspecting it to be Pheo. On CT imaging, it was Pheo, but it was not non-secretor. I did FDG because right now I couldn't do gallium DOTA. And so on the basis of that, some findings were, it was non-specific. So that is why my question is specifically, do we face this kind of problems where this tumors are non-secretors despite having the typical imaging features on CT? That is like huge number. You are saying it's around 50%.
Yeah. So if you're basically really suspecting a Pheo on imaging and the FDG is not specific.
Yeah.
Yeah. So the FDG can be really not like a lot of these tumors in the adrenal glands and sometimes in the retroperitoneum, if they're well differentiated and they're like the cluster 2 tumors can lack FDG uptake. So DOTATATE would be the first line. If DOTATATE is not available, and FDOPA is like, I don't know, like very few places have FDOPA in the world. So if DOTATATE is not available, then MIBG, I would say, because it's not unexpected that FDG is gonna show like just non-specific findings where like you could either have uptake in benign lesions or like you could have false negatives, basically. It is a Pheo or it is a well-differentiated paraganglioma and they lack FDG uptake. So MIBG would be better if DOTATATE is not available.
Okay. Thank you so much, ma'am. Thank you.
Of course, thank you.
Does the audience have any more questions for Dr. Mallak?
Yes, probably one.
Sure.
Thank you, Dr. Mallak, for your excellent talk, and you have touched almost every aspect of the disease. I would further ask you about the same thing of does tumor burden ensure us or direct us towards one type of lutetium, towards lutetium therapy or MIBG therapy when both MIBG and DOTATATE are positive?
Yeah, so we have like no clear guidelines on that yet. From discussions we've had with the group at NIH, the toxicity to the bone marrow might be a little higher with MIBG. So that's something that the group at NIH think that like if we have a lot of disease to the bone marrow, then probably Lutathera is going to be kind of safer. But like we still have like no clear guidelines on that. The MIBG therapy it's a tough treatment. Like even the side effects that patients experience is like they get tired. Like we go check on them and they're really tired, nausea, vomiting, and the toxicity from IDAM-131 is like quite a bit higher. But it works very well. Like in tumors that express MIBG, like we could see it. We see them improving. We see the tumor shrinking. Their symptoms way better. So.
The other question, Nadine, I was wondering, like, can we tandem these therapies in patients who are responding relatively young with fewer comorbidities, like you're targeting 2 different targets, right? VMAT with MIBG versus the somatostatin receptors with the PRRT. But again, I guess we have limitation of data on that.
Yeah, I mean, you mean like for younger patients, like which one?
Yeah, you mean you can start with MIBG if the patients are responding, let's do another with PRRT. So you are using 2 different targets.
Oh, you mean like for treatment, like if the patient relapses or if they need. Yeah, I think that's definitely a great idea. But yeah, it's gonna depend like also on the expression, like if they do express the uptake with the agent in question. But yeah, we considered that for a patient actually who had heterogeneous disease. We went on with MIBG first, and then they progressed. We imaged with DOTATATE and it was positive on DOTATATE, but the patient unfortunately passed away and didn't make it for the Lutathera treatment. But we were considering that. Like, unfortunately, they had a very aggressive disease and they didn't make it to the second treatment.
Dr. Takalkar wrote at Praveen, if DOTATATE is not available, maybe try OctreoScan with SPECT CT. That can potentially help as well, in addition to MIBG, and Dr. Mallak also mentioned that. Dr. Achet mentioned, yes, I agree. We published our center's experience with lutetium DOTATATE, showing a favorable outcome in these patients, and it is in unison. Thank you for your answer. Great. Thank you very much. I would like to conclude this webinar, and excellent talk, Nadine, and thank you very much for your time and for putting up such a great talk for all of us. It was really very helpful.
Thank you very much for having me. It's a great honor. It was very nice meeting you all. Hopefully we'll see you in person at some point in the future.
Sure, take care. Thank you.